Yes, Dr. Shreya.
I'm deeply grateful to Dr. Shukla sir, Dr. Pandey sir, Dr. Dedia sir, and Dr. Sharma sir for allowing me to speak on traumatic strabismus. And we have all our own publications of traumatic strabismus, and what can happen to trauma and strabismus can be a supranuclear structure to everywhere. So if you look at traumatic strabismus, it can be immediate and led. This is the algorithm how we'll find out which kind of trauma to muscle happened. Types of trauma which can happen to muscle can be contused, can be lacerated, can be complete laceration, can be snapped, pulled into two, can be a disinsertion, it can be a lost muscle, and we all know what happens in our blowout fracture. So I'm not going too deep into pathophysiology of blowout fracture. That can be lot many theories existing, but I'll directly enter into the management of traumatic strabismus. Most of the traumatic strabismus you find is incarcerated or entrapped strabismus. It can happen in type 1 fracture, type 2 enteral fracture, or type 3 enteral fracture. So we have to be worried for Y-type blowout fracture, which is the first important and immediate attention it requires. RMR also can be entrapped, which in this boy it was entrapped MR. It was entrapped superior rectus. So again, you have to get take support of all the radiological investigation and fix it immediately. The eighth thing can happen to muscle is flap tear, and ninth thing can happen to muscle is muscle can slip. So how to diagnose? We have lot many things to diagnose. We have to do thorough workup of a strabismus examination as we do with each kind of a strabismus, including ophthalmos, exophthalmos, pupil and everything. Could be supported by USG, CT, MRI, dynamic MRI or EMG. So dynamic MRI works very, very best when you're dealing with traumatic strabismus. Be aware of the contusion. When there is hematoma and contusion, you can just do medical management. Clinical diagnosis also can be done where the muscle is entrapped. Point to be noted is ocular motility, FDT and FGT. So these three things will definitely tell us where the muscle is and what we should do. This is a Q-tip FDT done in pediatric patient also, and again on operation table you can do FDT and FGT. According to FDT and FGT, we have developed our own algorithm. I'll not read a complete algorithm here. Later on, I can circulate. Anybody wants to take, can take. So when we enter into management, we have to look for oculocardiac reflex first, retrobulbar hemorrhage, open globe injury, CSF leak, and muscle strangulation. So these are the red flags. Within 24 hours, we have to intervene. So in that way, and when there is a simple contusion, till that time, if you have time, you can just manage it by medical management, prism, occlusion to avoid the diplopia. When there is muscle contusion, observe, simple anti-inflammatory, resolve with the complete restoration of movement. So medical management like steroids, antibiotic, and no nose blowing should be told to patient. Even in this patient, you can say it was acquired brows just because of trauma contusion, but then later on it resolved very well. Partial laceration, again, you can find out the muscle because half the muscle is seen in front of you. You can reattach it, and long-standing cases, sometimes you may have to reoperate the case. When there is complete laceration of muscle, don't be panic. Try to find out the muscle. Muscle usually doesn't go anywhere else other than its sheath. So trace the intermuscular septum of both the sides and try to find out the muscle. Look for the muscle sheath, and definitely if you are not panic, and at the same time you are not supposed to pull the globe away from the action. So otherwise it will push the muscle more and more into orbit. So that thing has to be taken care while doing this. This patient had complete disinsertion, and post-op immediately he regained the vision. Muscle can be snapped, pulled into two. So this way inferior rectus was definitely pulled, and as I said, trace the intermuscular septum, go to the muscle sheet, and definitely you can find out the sheet. So it's very easy to find out when there is muscle pulled into two. Snapped muscle is very easy to find out. You can hold with non-traumatic forceps and you can just suture it. So this person was 30-year person, and it was published. So when you are getting old injuries, there can be scar tissue, FDT, severely positive dynamic MRI works very well. Sometimes you may have to take the support of EMG. Lost muscle is really difficult to find out, and sometimes it's very old injury. You even if you find out, you don't get the gratifying result. So then the vertical rectus transposition works very well, and you can just do that transposition. Seventh thing can happen is incarceration. Again, as I say, timing of surgery and aim of surgery is to release the muscle properly. There can be too many ways to do, and too many implants are available in the market, but you should take care of the implant. But the thing is, you have to take out all the tissues from the maxillary sinus and take enough time to take out everything, and then appropriately put your implant to take care of this. So this is again a superior rectus entrapment, this is medial rectus entrapment, and this is lateral rectus entrapment, treated very well. Sometimes we may have to go to orthopedic surgeon and treat while they are doing their own surgery. So he fixated all the fractures, and then we took care of a muscle injury. But their FDT is at most important when you are taking care of muscle injury. This is post-op. Again, that can be endonasal route also. So again, so many complications can happen when you're doing orbital surgery. You have to take care of that. I'll not go into detail of each and everywhere here. The most important part over here is flap tear. So that you have to be aware, because all the muscle injury, it's front of you, but flap tear is usually is not in front of you. And more movement, the flap goes back and back and back, and then again you get the limitation of that action. So this flap tear again can be a longitudinal flap tear, that can be beveled flap tear or lamellar flap tear. You can just do dynamic MRI. All the time you will not be able to get the result with dynamic MRI. Clinical judgment. This girl had injury, and you can see the muscle, you can see very good movement. So you never expect any injury, but on table when we took the patient, you can see medial rectus was, the anterior part of medial rectus was slide back, and then we reattached. Here you have, when you are just tying the suture, you have to push the globe towards the action. Otherwise, again and again it tears. So that is the most important part we have to take. This time when we are tying this, we have to push the globe. Tell your assistant to push the globe. So this is the way we completely suture, and this is post-operatively. So again, another flap tear was happened, that was oblique flap tear, and this is post-op. Entrap muscle, I've already told so many things. When there is tight muscle, again, you can just take care while just dealing with. When you open, and you can see, even my speculum is not going. I'll take only 1 second, so it's last slide. So management of flap tear is at most important. Sleep muscle you can find in its sheet only. So just try to find out its sheet. This is post-sinus surgery. So sometimes you can get the iatrogenic traumatic strabismus, which also you can take. So again, then later on you have to take some of the things like this vascular cause. You have to observe patient. Just simple observation can tell you so many things, like CCF. The globe is pulsating globe. So there you should have judgment of treating the patient while ligating first, and then do the things. I'll not go into paralytic strabismus because it's same as traumatic strabismus and the treatment remains same. So I'll just end my talk here. Paralytic strabismus is the same, and I'll not go. So just traumatic strabismus we can take care here. Thank you so much. I'll end my talk here.